Hello, everybody. Too many people here today. This is the last Journal Club for the academic year. So let's start. So my presentation today is about the effect of electrorotary settings on particulate concentrations in surgical fluid during tonsillectomy. And this article done in Department of Otolaryngology in West Virginia University and funded by NIOSH. So tonsillectomy is the second most common surgical procedure in the US, especially in children under 15 years old. Surgical indications for tonsillectomy have shifted over the time from infectious to obstructive reasons. And there are various techniques that people can use to remove the tonsils from hot to cold. So hot meaning using energy to take out the tonsils, like electrorotary, one scalpel, radio frequency, and there's other like cold methods like stainless steel micro debrider that can cut and suck in the tonsils out of the patient, from the patient. So the paper mentioned that 57% of surgeons, they elect to use electrocautery, meaning that this is a very efficient way for them to do the tonsillectomy. And this is increasing. There is a trend towards this electrocautery usage for tonsillectomy. Surgical plume, which is our main focus of the concern, it's created when the electrocautery heats the target tissue and to the boiling point, and then the membranes are broken and lead to dispersal of the cellular contents. And there are a lot of things inside this plume, from chemicals to blood products to tissue products to viruses and bacteria as well. So why it's important? I think this diagram is very familiar to many of us, because this is I borrowed this from the IH class notes. The size matters because here's the thing: the electrocautery creates particles roughly 0.07 micromillimeter in size, very tiny particles. And this can get deposited in the alveolar space or the pulmonary region, here at this level, because it can pass down the whole respiratory tree down there. Because if we remember from our IH class, respirable fraction typically smaller than 10 micrograms, and then the thoracic fraction less than 20, and then the inhalable fraction less than 100. So by this size 0.07, it's very tiny, so it can reach the deepest level of the respiratory tree. Why this paper? Limited information exists regarding exposure to surgical plume in pediatric surgeries, like tonsillectomies. But there is a lot of research done there about surgical plume and other surgical fields. But for this field, I think they mentioned this is the first study to do this for tonsillectomies. And the study aims to evaluate the concentrations of particles during tonsillectomy, just assessing the EC settings and the use of surgical evacuation systems. Surgical plume evacuation systems. So the methods for the study. So the design: tonsillectomies in children less than 15 years old, with and without surgical plume evacuation. And The technique, it's the subcapsular dissection, and this is done by the senior author of this article or very experienced residents, meaning that at least 50 tonsillectomies were done by the resident who's doing the study. And then the electrocautery setting adjusted either to 12 watts or 20 for tonsillectomy. And then the evacuation system, they used this Yankauer suction. If you are familiar with the OR setting, this is hooked to a wall suction. However, I should say this wall suction is designed to suck fluids, not necessarily the surgical plume or like smoke. And then cases were performed in the same operating room. This is a good thing. And also there was a turnover time between the surgeries, about 1.5 hours between surgeries. The sampling was done by this device, the Disc Mini. This is the picture. However, I should say that the range is 20 nanometers to 300. This means the largest particle that this device can detect is 0.03 micromillimeter. So it's just not up to the 0.07 that the EC can generate. And then they also deducted the background concentration. But this done, just we need to be careful here, like empty operating room each day. They didn't mention it's necessarily the same operating room that they use for the surgeries or not, but just an empty room to get the background measurement and then deduct this from the measured amount for every surgery to make like some sort of controlled comparison between the groups. And then patient groups were put in 4 groups according to the setting or using of the evacuation system for the smoke or not. So for the setting, so the 12 means the 12 watts with the evacuation, and then 20 with the evacuation, then 12 without and 20 without. Again, this subtracted the background concentration, and then they used ANOVA to compare between the 4 groups. The significance level was set for P less than 0.05, and then they also did the Pearson correlation coefficient to assess the relationship between the particle number and the electrocautery time. So 36 patients, again, assigned to 4 groups. And then they found that the mean particle number concentration were 1,661, and then 5,000, 8,000, 78,000 for the groups as we go from the least EC setting with evacuation system to the highest EC setting without. So I know the numbers may be like not making sense for you right now. I'll show you that the figures will make more sense. And they found significant difference for the without evacuation of the surgical plume, and was significantly higher, this group, which is 2 groups with the 2 settings. And then also the correlation with EC time, there was no strong positive, between the concentration, but there was like some moderate correlation only in the 12 watts with evacuation system. Also, the average duration was similar for those 3 groups and was longer for the 12 NS without evacuation group. And the maximum particle concentration was in the 20, you can imagine, like, the highest EC setting without, evacuation system. And there's the range of the values, but I think this will make more sense to you. So these are the 4 groups, and you can see the mean, this dashed line. You see it's getting higher as the setting is getting higher and no use of surgical evacuation system. And these are the individual surgeries, like these dots are each surgery, so you can see the concentrations for each surgery. So in this group, they are like, within like very narrow range, but for the 12 without evacuation system, just like, high range. And here's the EC time. You can see the time, this is like, the range and then the mean. It's just longer for this, which just raises some questions. But the most important part is actually there is a negative correlation between the EC time and the concentration of the particles, which counterintuitive, just like, you would expect more surgical plume generated with the longer time of using the EC, right? But this is like what they found. It's just negative correlation. So surgical plume, because of the nature of the ultrafine particulates in surgical plume, there is a lot of work we need to be done to understand what's the significance of that. Is it harmful? Cumulative effect. Do we have more, morbidity or just like cancer, lung cancer or something like that in the OR personnel more than general population or not? I mean, we need to know more about this. And then we need to know more about different devices that we use that can generate smoke in the OR, because they are not the same and the particulate size is different from a device to a device. And then smoke evacuation system. So there is no standards or regulations that force people to use the smoke evacuation systems. However, it's recommended by NICE and OSHA. So, but it's not like a mandatory thing. And then we need to know why people don't use them. If it makes sense, the surgical plume or the smoke is hazardous, why we don't use them. And then room ventilation, this is a very important concept, and we need to quantify this when we do our sampling or measurements, because this affects the overall result, because it's different from system to a system, from a room to a room. So we need to make sure that we account for this. And then again, making people aware of the risk of being exposed to the surgical smoke is really important, that this can drive the cultural change towards being more careful or using the surgical evacuation, like smoke evacuation systems. Especially, I should say, the surgical masks are not protective. And actually, if you think about it, these masks were designed to protect the patient, not the surgeon. So just like prevent anything comes out of, personnel respiration or mouth, just like to the surgical field, just protect the patient, not the personnel. And we should say they only prevent the large particles, not the tiny, very tiny ones. And they are open from the side, so smoke can get in even large particles. Okay, also about the setting. Can we achieve the goal with lower setting of the electrocautery, or just, I like the, the rapid higher, the higher setting that makes me like, go through, my incision quickly. So, but what are the consequences to this using the higher settings? If we think about strength, for this study, actually, it took me a long time to think about strength. So clinical relevance, yes, there is like, there is a need to know about this, especially for tonsillectomies, because nobody done anything about it yet. Methodology, yes, they try to minimize the variables using the same room, same surgeon, experienced residents, trying to subtract the background concentrations. They tried their best. However, I should say for the methodology, we'll talk about this, there are a lot of improvements can be done on that. And statistical analysis, yes, ANOVA is the best to use to compare between the groups. But weaknesses, small sample size, lack of randomization, this is an easy thing to do. To use smoke evacuation system or not, or use the higher setting or the lower. Why they didn't do that? Easy thing to do. And then indication for the surgery wasn't considered. Indication and also the pathology of the tissue, because the pathology can affect what's generated when the heat is used to cut through this tissue. And then I don't think it can be generalized because it's just very specific, tiny field, open field. It's not comparable to other surgical fields. So we cannot generalize to all the surgery field. Okay. This is the article, and here's my first question. What factors do you think could contribute to the observed negative correlation between the EC time and the particle number in the study? Why do we see that? I mean, it doesn't make sense. If we use more electrocautery, longer time, generate more. Yes, Carl.
You've got more virgin tissue at the beginning versus the longer you use it, the more cauterized it gets, so less particles.
Yeah, makes sense. So like the concept of like decreased tissue volume. This is what you mean, right? Yeah. Okay. Yeah. What else? They didn't mention this. They didn't make a comment on this where they should. And I just have my thoughts, and I just like to listen to your thoughts too, because just it's interesting to think about it. So my thoughts are the technique, because according to some people may burn more than needed versus like those skilled ones who are experienced, they can very just like use the same time but like burn less maybe. And then maybe as the time extended, there is more efficient suction of the smoke, because if you think about it, there is the main surgeon, the assistant, using the anchor. This is like a tube that gets to the smoke before it goes to the device that measures the concentration. So maybe more efficient smoke absorption. Also, as you press long on the button for electrocautery, I think the output gets less, just like with the, it's a function of the device. And you can hear the tone is getting, weaker as with your long press. For some devices, maybe. However, they said they used the same room, they used the same device, like the electrocautery device. One more thing is that to achieve hemostasis in this study, they used suction coagulation, which also can, and they didn't account for this. They didn't mention it anywhere else at the beginning in the methods, and that's it. And then they can affect, it can take some smoke out when they use it. So there is, a lot of things can affect this negative correlation. However, if this is the real world scenario, we should account for this. And I have no problem with the negative correlation, but just we need to understand why this is happening. Okay, my last question is, what modifications in the study design do you think can be done to improve the outcomes and to make it more applied to at least to the field of tonsillectomies? So, yes.
So did they only use one type of electric cauterization system, or
Yes.
do you think it would have been beneficial if they tried different ones available on the market?
Yes, you can change systems for sure, and with different settings. And also, actually, the smoke evacuation system that we used, this is not the regular smoke evacuation system that we should use. This Yankower thing is hooked again to a fluid suction on the wall, just for fluids. But there are other smoke evacuation systems available out there. It's, you know, to be specific, for some devices that I used before, with the tip of the electrocautery pencil, there is like another tube on top of this that can suck the smoke out. So as it's generated, it sucks the smoke to a filter. And this filter, at least 3 stages that can, you know, handle the smoke. Because what do you think will happen to the smoke that's, you know, sucked by the, you know, fluid suction on the wall? What will happen for it? It's not filtered. Somebody emptying the can get, you know, can inhale this amount again. I mean, we didn't do anything. So we need to do a real, you know, like smoke evacuation system here in the study that, you know, because now it will make sense because we get rid of the smoke. Second, they measure this at the, you know, level of the surgeon. What about other people around the room? They are not exposed to the same level of smoke. The surgeon, the assistant, and then the circulating nurse, you know, away from, you know, the surgical field. And then we need to measure at least at 2 points. And then this mini disc that they use for measurement, we need to have like a higher range, more range to account for those, you know, particles. And we need to identify what are those particles. 95% is water of the particles. Only 5%. We need to quantify those. And actually, I have another article. I just got it yesterday. I didn't fully read it, but it will be interesting to read it. It's from good, you know, important surgical group. They say this surgical smoke thing is not real. Actually, all what we see is just water particles. It's not harmful. Even there are some trace elements of hazardous materials, but it's not up to the level that we should worry about it. So we need to understand the actual composition of the smoke. It's not just the smoke, what's in the smoke. If it's water, then it's water, then no problem. But if it's, you know, all these harmful or hazardous materials, then we need to pay more attention. So I think these are the modifications. And when I first chose this article, I thought it would be like, you know, I don't know. As I read it more, I realized that, you know, a better job can be done on this. And actually, I read other articles that did a better job on this. Maybe it's not in the same surgical field, but it's still like, you know, make more sense when we, if we can consider it or not. Okay, any questions? Yes.
What do you think about like the time it took for them to like record the procedures? Do you think that it was generalizable to like the length of how long the procedure would take?
Yeah, I think they just like, you know, recorded only the time when the movie is just like is in work. This can, you know, introduce some uncertainty because it needs like a very accurate recording of when on and off. But yes, the usage of this, like typically this fast surgeries, yeah, the total time, yeah, I think it's okay. Yeah. But again, the experience of the surgeon or the resident make a difference because you can use the movie long time, but you are cutting in the wrong place until you reach, you know, the needed point to like get this like tonsils out of its bed. So it's just, you know, inter-user variability, and maybe if one surgeon is doing the whole study will be better, but I think the time is representable of like, you know, the actual time that the tonsillectomy needed for like to use the AC. Yes. Other questions?
Anything else?
Okay, thank you so much.
Oh, look at that thing.
Oh, it's alive.
Terrifying. We're worried about breathing each other's tonsil smoke. Jeff, thanks very much.
I project, so this is gonna blast everybody.
You gotta just put it like, well, I made a mistake the other day of using it, putting it really close to my mouth and that blasted everyone, but. On if you're, or turn it on when you get on.
I'm gonna do that.
It's on the top.
Oh, it's a little off.
Yep.
We're on it, we're on it. All right, so thank you everybody for taking the time to be here today. The paper that I'm going over is the prospective study of biomechanical risk factors for second and third metatarsal stress fractures in military recruits. All right, and those are all the authors there. So I'm sure all of you think about your foot bones on a daily basis, but I want to make sure that everybody's on the same page. So these are your bones, and this paper is specifically focusing on our metatarsals, which are these guys right here. The second and third ones are right here, and I'm going to be abbreviating these at MT or as MT at some points. So I'm going to be going over the introduction, methods with respect to data collection and statistics, as well as the results, and then discussion, summary, conclusions, and then strengths and weaknesses and questions, basically standard journal club stuff. So stress fractures are often caused by a repetitive weight-bearing task. So the most commonly affected populations that have this condition tend to be in either sports or in the military. And stress fractures are basically tiny little cracks along the bones, just like in that picture right there. So the Royal Marines specifically found that 4 to 8% of their recruits had stress fractures during their 32-week training period, which is actually a lot longer than the 13 that people usually have in basic training in the United States. And whenever these people sustain these injuries, there is a significant time away from work or training that obviously impinges upon productivity. So the metatarsals as a whole have been identified as an area for, or that's very likely to have stress fractures, but the second and third metatarsals specifically are the most common ones to be affected. The reasoning for why these two are considered most prone is different. So the second is apparently more sensitive to vertical loading according to prior literature, and the third is more prone to damage if subjected to lateral loading. And there's a couple of theories for why that's the case. So dorsiflexion is when, this is actually, I forgot about their perspective, it's like this. And there is an assumption that if you have limited range of motion for your passive ankle dorsiflexion, it may be causing a premature heel rise and an increase in loading at the metatarsal heads closer to toe off. Alternatively, and the paper doesn't go into this a ton, they are possibly, current theories kind of assume that arch height and ankle abduction are two possible contributing factors as well. They didn't elaborate on how arch height specifically could be a problem, but for ankle abduction, if this is my foot and this is the midline, abduction is going away from the midline and then adduction is going towards it. So we're all clear on that. So this was a prospective cohort study for a military recruit population, specifically the Royal Marines of the UK, undergoing their 32-week training period. And this study was used to identify risk factors for the second and third by specifically examining these two metatarsals alone. Previous work has usually lumped the metatarsals together, and these authors specifically went out of their way to isolate these two to make sure that there isn't any sort of relationship masking that clumping them together could possibly cause. And they specifically did this by measuring passive and active range of motion and plantar pressure. So they only recruited male recruits during their first week of training for a total of 1,065 individuals who were injury-free at the very beginning. Individuals during this time frame who expressed any sort of foot pain were given an MRI to confirm that these were or were not stress fractures. At the end of this period, 14 of these individuals had a unilateral third metatarsal fracture and 7 a second metatarsal fracture. And for all of these individuals, age, height, and body mass were recorded. So they collected kinematic and pressure data from these individuals. And it was unclear in the article whether or not they collected running data from all 1,065 and at what point they did that, or if they specifically chose individuals, which I found kind of a concern. So before they collected data, they had participants practice running across this walkway a few times. And once they did, they collected pressure profiles using a plate very similar to this one at 200 Hertz. And from this, they're able to determine peak pressure magnitudes and when that peak pressure occurred during stance phase. This is the actual software that they're using. It's a bit of a black box, but it seems to be able to delineate each of the metatarsals and other relevant components of the foot from there. It was also used to determine dynamic arch index and then general foot abduction angles. They also measured running velocity using photocells simultaneous to the capture. And in order to collect kinematic data, or basically motion data, they use an active motion capture system. This one exactly, I think that's even the same marker set that they're using. This is an active system that they specifically chose to look at active ankle dorsiflexion range of motion while running. And they placed markers along anatomical landmarks as discussed in the paper, and they processed these angles in a custom MATLAB script, not really explaining how they calculated it or why they had specific markers. And from this, they obtained peak ankle dorsiflexion values. They also did a passive ankle range of motion test. That's like a standard clinical weight-bearing static lunge test, and that was done with an old-fashioned goniometer. So when it comes to the statistics, they calculated means for any dynamic variables as an average of 5 trials, and for anything static, they did it for 3 trials. They did statistical comparisons to a no injury group, and from a stability analysis that they had conducted prior, they pulled data from 150 no injury individuals. And then they did the statistical analysis in Stata version 14.1, then doing separate univariate regression models for between group comparisons. Once they did that, they did a multinomial logistical regression model to predict injury risk, and they specifically determined candidate variables based off of whatever univariate regression values had a p-value of less than 0.1. And they iteratively removed these variables until only statistically significant ones were applicable, or that had a statistically significant impact. And then this model was apparently estimated using a Huber-White sandwich standard error and a 95% confidence interval. Personally, maybe this speaks to my lack of experience with statistics or epidemiology, but I had no idea what that was. So apparently this is also referred to as a heteroskedasticity consistent standard error. I understand why they would use the sandwich term now, but apparently to my understanding, it allows for the fitting of a model that has heteroskedastic residuals or residuals of unequal variance. I looked into this further to not kind of go on too much of a tangent, but apparently they use the sandwich analogy because the bread of the model is variance based on the model, and then the meat itself is the empirical variance based on residuals. And I'm assuming the complicated math behind it would probably make the analogy make more sense, but now you know and now I know. So the resulting coefficients from this model were then back transformed to relative risk ratios from log odds. So this is the result table for their univariate analysis. You can take a second to soak that all in, or I can highlight the ones that were statistically significant as far as the regression model was concerned. So the 2 here that are in green, if you were to look over there, it seems that they use a threshold of 0.05 and 0.01. But for those green ones, I circled them even though they are past those ranges. And that's because these were still factored into the regression model, even though it doesn't fit those criteria, which is interesting. Otherwise, foot abduction, the 4th metatarsal peak pressure, 1st, 2nd, and 3rd metatarsal time of peak pressure were statistically significant with at least 0.05 is I guess, the upper threshold. So looking specifically at the multinomial logistical regression, the variables that had any sort of impact were the arch index, the age, foot abduction, and then the time of peak pressure at the 2nd metatarsal. And this just depended on the exact metatarsal you were looking at. So for the 2nd metatarsal, the arch index and then foot abduction were the 2 most impactful variables. And then on the 3rd metatarsal side, it was age as well as time of peak pressure at the 2nd metatarsal, even though we're specifically looking at a model for the 3rd, which was interesting. this is what the data looks like visually, starting with the second metatarsal. So the arch index one is there on the right, and then the other one on the left. I forgot perspectives. Anyways, this one closer to me, the lower the arch index, you could say it's approximately synonymous with arch height or the high arches. It is an oversimplification of a lot of other classification schemes for flat foot, but this is what a lot of places do in clinics. And then for foot abduction, you can see that it goes 0, 2, 4, and so forth, but then it also includes that area for -2. Negative abduction is a deduction. So instead of pretend this is my right foot going like this, people are going like this, and this seems to be elevated or be associated with an elevated amount of risk. So then if we look at the third metatarsal, basically for our age relationship, the younger the person, the higher the risk. And then for the time of peak pressure at the second metatarsal, the closer you are to toe off. So basically, well, it's kind of what it sounds like. You're about to like lift off of your toes. And then the greater the risk associated with obtaining a fracture at the third. So the authors concluded that there was a limited range of motion, passive or otherwise, that was ultimately not impactful with elevated injury risk, even though they placed a pretty high amount of precedence in their background saying that this is probably a concern. Specifically looking at the second metatarsal, they found that the attributes that were considered high risk were associated with supinated foot characteristics. So basically high arches and then an adducted foot, which is basically, or at least a low abduction. So people's toes were more likely to be pointed inwards towards one another. Apparently, they found that this was consistent with existing literature regarding high arches and an elevated risk of metatarsal stress fractures. Now, going on to the more confusing one for the third metatarsal, young age was considered a risk factor, which apparently aligns with current literature. And they basically said, we're not entirely sure. Somebody else needs to do a study that evaluates bone density and cross-sectional areas. That is not our thing, thank you. You'll find that that is true for the next point as well. So let's see. Basically, in terms of practical implications, they found that what this really means is when you're designing training regimens for individuals that are younger than 25, you want to make sure that it's not going to possibly break their bones, which is generally a good idea. So the time for peak pressure at the second metatarsal was considered a risk factor for the third metatarsal, which sounds really weird. But basically, a delayed propulsion time, so basically the latter stage of toe off, was considered to cause an elevated risk. And truthfully, the discussion on this was kind of vague, maybe a little open-ended. They threw out a couple of ideas. One of them was that later foot abduction might be diminishing their moment arm and might be subjecting the metatarsals to elevated force levels. And the third metatarsal is going to be more sensitive to AD and abduction. If you remember my discussion at the beginning, the third metatarsal is more sensitive to horizontal forces, which AB and adduction would correspond more greatly to. They ultimately said that somebody else needs to do more research to understand the underlying mechanism, but just kind of keep that in mind. So to reiterate or wrap things up, data was collected from 1,065 male Royal Marine recruits during their first week of training. They collected motion capture data, pressure profiles, and then conventional weight-bearing lunge test data. From this, they did univariate and multinomial regression models. And then they determined that age, ankle adduction, time of peak pressure at the second metatarsal, and then a low arch index were considered risk factors in obtaining an injury or a fracture at either the second or the third metatarsals. And in terms of practical advice that they could hand back to the military, they said, make sure that you create your regimens as to not fracture your recruits' bones if they're really young people. And then also that other people need to do more research to look at bone shape and density. So in terms of the strengths of this paper, this is probably the first prospective biomechanical study for risk factors that I have seen in quite a bit. It was a pretty ambitious undertaking, trying to collect, if we assume that they collected like 1,065 people's data, which I don't think they did, that sounds pretty rough. But even if you had to do that from 150 people, that also sounds really terrible. So I commend them for going through all the effort. Also, this is one study that actually justified the number of participants they tried to collect from as part of their study. for the 1,000 minimum, they went slightly above that to make sure that they had captured an appropriate trend, which I find in biomechanics literature is sometimes not the best. And then I would say that they had a very thorough analysis approach since they considered the active and passive range of motion, velocity, and a bunch of other factors. And even if it didn't mean anything, at least we can say with slightly more confidence that they may not be as impactful. On the weaknesses side, they did not account for gender, smoking, alcohol consumption, or race, which I did find pretty interesting because to my understanding, those are pretty standard epidemiological factors. And I was kind of curious if anybody had any thoughts on why or why not that would be a good thing to consider or keep out. And then in terms of their kinematic and plantar like motion capture data, it was pretty unclear at what point they collected their stuff for the fractures group. If they didn't collect after they got injured, that means they must have collected from all the people, or a very high portion of them, which seems inefficient. But if they collected the data afterwards, that would heavily change the interpretation of the results. And the fact they didn't clarify that was a little concerning. So there was also a pretty limited rationale in some of their data collection choices. They did not say how their custom MATLAB script determined angles. It had an awful lot of markers that frankly didn't make the most sense to do, and it was only looking at one plane of motion, so it was a bit different. They also didn't include any citations on how or what they base it off of, if anything. So I know people are probably a little checked out. We are at the 15-minute mark, but I want people to read this and tell me what's wrong with it, besides the picture being a little grainy. Any takers? I'm staring at a few people, specifically teammates. 5 more seconds.
Well, individual anatomy can be like individual proportions could be different. So like what's inferior, just inferior to the muscle belly of the gastroc for one person could be very different for somebody else.
That is actually a very good point, and I appreciate you put a little more thought into this. I was just gonna say they misspelled calcaneus. I thought, and I have a feeling that people who reviewed this journal were like, well, these people are British or Commonwealth country, blah, blah, blah. Maybe they spell it differently. Sometimes that is true. I actually Googled it, and Wiktionary is definitely legit, but they had an entry. But as you can see, it literally is just a misspelling of calcaneus. So somehow that got through the cracks. And so, yeah, I just wanted to point that out because I'm a little petty. And with that, here are my questions. So should gender, smoking, alcohol, and race have been considered for this analysis? Do you think these results will look the same if they did this study for a US military population? What do you think could have been done differently? You can read the rest of the question.
Let me ask, who's had a stress fracture in this room? Three. Okay, good. Can you go to your second slide if you don't mind?
The one with the foot bones.
Way at the background, way at the beginning.
This one?
Okay, next one. There we go. This slide. There's an error on this slide. What's the error? I don't expect the non-MDs to know, but the MDs for sure should know.
Like a full transverse fracture. Oh,
Okay,
A lot more intense than stress fracture.
so everybody's had stress fractures. You're all walking, aren't you? It's not repetition at all. That's baloney. What is the risk for it? When did you get your stress fractures?
Want to increase the amount
Of,
of like your mileage or something?
you gotta have force.
Or your
You have to
weight.
have force and it's unaccustomed. The risk for stress fractures is unaccustomed forceful use. That's what causes stress fractures, which is why it occurs in military training settings. Okay. You could find this exact quote all over the place on the web, but that's the issue, and they're not really studying that in this paper, right? Because everybody's military. So I just want to make sure everybody knows the most important part about stress fractures, because by definition, a fracture exceeds the tolerance of the tissue, right? By definition, it's a failure.
I guess the takeaway is don't trust everything you find online, huh?
Well, there's more to it. And they're overlooking some major risk issues here, which may have been helpful.
But I mean, some of this could be interesting for some of the early entry stuff or teams and whatnot, where you can focus, you can give the DIs material on improving the range of motion in the ankle, what exercises to do that sort of stuff, just to lower risk, I guess.
If you're going to try to prevent stress fracture in a military setting, what are you gonna try to do first?
Lower standards generally.
Lower standards? No, because it's gonna work. Doing that.
I think a lot of the people doing these trainings are carrying backpacks that are like 75 pounds, so I think probably lowering that even ever so slightly could be a consideration if you can make a sufficiently compelling cause for it. Especially, like, which picture was it? The one prior. Like, that guy, I think, is wearing a full pack right there in the middle, and he's running at full force. I don't know if it necessarily, I have a feeling that it would just necessarily take it once for that to happen, because it seemed that most of their training happened like this.
It'd be helpful to recommend people do some conditioning before they ever get to the bigger camp to start that process of ramping up. And then you have the issue of just how high do you push it on day one.
Now, I'm just the administrative assistant, but what kind of footwear were they wearing?
They were wearing the standard boots. like
Standard
that.
boots.
Yeah.
Okay, and see, I think that probably, I don't think those boots are worth crap sometimes. So that right there probably is one of the problems.
Yeah, one of the things that I didn't quite highlight was that they did this study barefooted so they could get the pressure profile. So they said, whoever's gonna do this in the future, it's probably not gonna be us, should be doing this with like pressures insoles within shoes to kind of gauge the profiles. And then from there, they can probably make some better recommendations. Yeah, I do think that the point on conditioning people, I mean, kind of the whole point of the camp, if they can kind of dial down certain things, if they know that people are within those groups, I still do think that that would be important, so.
Well, there are people here from the military. I don't know how well that would go over in the military to separate people out into two camps.
Probably not.
Harder,
Especially.
Heather's shaking her head.
Hard to completely water down the training. There's a lot that, and they always look at trying to adjust due to like their changing populations, you know, the militaries are widening their or loosening their exclusion criteria and widening their age range, so they may have to consider it, but it is hard to kind of maintain a standard and prepare people well if you can.
You have to have some
Strengthen.
standard, right?
Yeah.
Same with firefighters, like, they have to be able to do their job eventually, and a lot of, especially like special operators and stuff, they have to carry 80 pounds into the field, so like, they have to be able to do it, but there's certainly like things that can be taken into account in terms of preparation, especially like Dr. Hammond said.
Sure. I am actually kind of curious if people have any thoughts on the second question. So the training, at least their equivalent to basic, to my understanding, is 32 weeks, whereas in the United States it's 13. I don't know if that would have any bearing on why people are more likely to observe these types of injuries here as opposed to the,
It's a lot packed into 13 weeks. So this was British Royal Marines, and it's a very gradual progression. But Marine Corps boot camp is generally called to 13 weeks, and at the end they do what they call the crucible, and that's a weighted ruck for many miles over vertical gain and drop and stuff like that. So, and that goes over the course of a week, and so ramping up within 13 weeks to get their body ready for that is, if it is a jump in, if stress fractures are caused by a jump in your tissue's ability, more so than like what it's capable. That's a lot of crap shoved into 13 weeks.
so you're saying that there might be a higher likelihood of stress fractures if you did this study for a US cohort? Cool. Any other comments?
I think one thing they could have done is done MRIs of like the entire cohort instead of just the people that were symptomatic, because you could have asymptomatic stress fractures. I think that would have changed the data and results a lot too. But it's expensive and takes time, so.
Yeah, a lot of countries with conscription will do that because it's not, if you have the right systems in place, it's not terrible, but still.
So based on the discussion we had about the primary cause of this, what data are missing that should have been collected?
Baseline cardiovascular or like baseline physical.
Yeah,
Readiness.
measures and stuff like that, and how much they were able to perform, or some measures of that, you know, how far they thought they could run, anything like that on a questionnaire would have been better than nothing.
Yeah, I did find it interesting that they didn't include any like just baseline data on how fit these people were. Obviously, they're going into their marine, so they're like presumably a little fit, but I don't know, I feel like that could have been controlled for a little bit better.
Did they monitor and test both feet, or did they only do 1 foot?
They only did 1 foot and they selected it at random, which is also an interesting choice.
So if they did it at random, could they have looked at their non-fractured foot? If it was somebody with a fracture?
That's a good question. They probably could have, but they did not really say much beyond we scanned people's feet and we picked it at random.
Which foot would you predict on average would be more likely to be stress fractured? Why?
Dominant.
Protective.
What do you mean protected?
You're gonna put on your day-to-day life, you're gonna put less weight on it. So when you.
I agree with Chapman,
Thinking dominant foot, but
which is the dominant foot for most people.
the right.
The right, that's right. Only got the answer right.
Wow.
Usually-
Admin knows something.
Most people are left-footed and right-handed, so you expect the right foot to be fractured, more likely. In situations where they're each giving the same amount of weight and effort on both.
Any other thoughts?
That means taking them at random is not the best idea.
Generally isn't, honestly. Anyway.